Good morning, everyone. So our first lecture today is dysrhythmias. I usually do this in two parts to break it down a little bit easier. So there's four properties of the heart cells that allow the conduction system to start an electrical impulse and send it through the heart tissues, and it stimulates muscle contraction. So first is automaticity, and that's the ability to initiate an impulse spontaneously and continuously. Excitability is the ability to be electrically stimulated. Conductivity is the ability to transmit an impulse along a membrane. Contractility is the ability to respond mechanically to an impulse. So with the conduction system of the heart, and of course you should know this, it starts at the SA node to the AV node, the bundle of His, the right and left bundle branches, and then to the Purkinje fibers, which transmits the impulse to the ventricles. With nervous system control of the heart, the autonomic nervous system control, this plays an important role in the rate of impulse formation, speed of conduction, and strength of cardiac contraction. It affects the heart, the vagus nerve fibers of the parasympathetic nervous system, and the nervous fibers of the sympathetic nervous system. So with the parasympathetic nervous system, it decreases the rate of the SA node and it slows impulse conduction to the AV node. The sympathetic nervous system increases the rate of the SA node. It increases impulse conduction of the AV node, and it increases cardiac contractility as well. So with dysrhythmias, it can be a disorder of impulse formation, conduction, or both. Things that you need to know, such as the SA node, that's the normal pacemaker of the heart. And this fires between 60 to 100. So if the SA node fires more slowly than a secondary pacemaker, the electrical signals from the secondary pacemaker, those can escape. And the secondary pacemaker will then fire automatically at its own intrinsic rate. So your secondary pacemakers would be the AV node, which fires 40 to 60 beats per minute. And your AV node is also known as the gateway to the ventricles. And if the AV node fails, then it's going to fire at the His and the Purkinje fibers, which is 20 to 40, 60 beats per minute. So with EKG monitoring, it's a graphic tracing of electrical impulses produced by the heart. So when you think about the inside of the cell, when it's at rest or in a polarized state, it's negative compared with the outside. When a cell or groups of cells are stimulated, the cell membrane changes its permeability. This allows sodium to move more rapidly into the cell, making the inside of the cell positive compared with the outside. So a slower movement of ions across the membrane restores the cell to the polarized state, and that's called repolarization. So depolarization causes contraction. So the myocytes are polarized at rest. Depolarization, that's a current through the myocardium, and it stimulates the myocytes, which become positive, and it causes a progressive contraction. So fast-moving sodium ions carry the cell-to-cell conduction of depolarization. So I'm going to skip, well, actually, just so you see here, the EKG recording, if you look at the photo, we discussed this last semester, how, as well as in pathophysiology, your P wave. The P wave represents atrial contraction. The QRS represents ventricular contraction. And that T wave represents ventricular repolarization. So the next slide shows a photo of the heart and the leads that will be placed on the chest. Now, this gives you 12 views of the heart. So imagine if you're suspended above the air and you have another friend who is lying on the floor. And you can see the inside of the heart. You're both going to have two very different pictures. So kind of keep that in mind. And we'll talk about the EKG in part 2 of dysrhythmias. I think that's in maybe 3 to 4 weeks. When we talk about limb lead placement, I'm sure you guys have seen patients who are being monitored by telemetry. And they have certain colors on them. It's white, black, green, red, and brown. So, in the way I always memorize to put the telemetry leads on would be white is right. So it's white clouds over grass, green. And then on the left, you have smoke, which is black, over fire. So smoke over fire. So the other one would be red. And of course, the one that you put in the midsternal area is brown. The next slide shows anterior precordial lead placement. So when you look at these, you see where V1, that is right of the sternum, that's at the 4th intercostal space, and adjacent to that is V2. So V1 and V2, those mainly look at your right side of your heart, as opposed to V3 through V6 look at the left side. And you can look to the right of that photo and see where the leads are placed. Posterior lead placement. So this would be your V7, V8, and V9. So if there's some changes in here, this could designate whether the patient had a posterior MI. So I'm going to skip on to the next slide. And I just want to talk a little bit about EKG monitoring. So when we talk about the P wave is atrial contraction. You might hear atrial depolarization. Well, this means both atria are contracting at the same time. Your PR interval, that's measured from the beginning of the P wave to the beginning of the QRS. And so the PR interval, it's like a pause, and it's allowing the ventricles to fill with blood. Now, sometimes patients have a prolonged PR interval, and then they could end up with some heart block, which we'll discuss that in a later lecture. Next is the QRS. So the QRS interval, that represents ventricular contraction, and of course both ventricles contract at the same time. So when you're looking at this, you see the Q wave. So not a Q wave, but the Q, that is a downward deflection. The R is the very tall peak, that's an upward deflection, where the S is a downward deflection. The ST segment is measured from the S wave and the QRS complex to the beginning of the T wave, and that represents the time between ventricular contraction and repolarization. repolarization is also known as diastole filling. So that's a flat line. The T wave represents ventricular repolarization. The QT interval, this is measured from the beginning of the QRS to the end of the T wave. And that represents the entire electrical depolarization of the ventricles. So we're looking at the P wave here. So again, the P wave should always be upright. And so that is what a normal P wave looks like. And you know the SA node function is firing. With the AV node, again, this is when the depolarization slows through the AV node, and that produces a brief pause of the PR interval. And again, that's just allowing time for blood in the atria to enter the ventricles. The QRS, which we talked about, this is when you have the depolarization. It shoots rapidly through the bundle of His, the bundle branches, the terminal filaments of the Purkinje fibers. And so with this, and this is like a nice little picture here because you can see where you start to measure and where you stop measuring. So I'm going to skip over the T wave. I think we've already discussed that pretty good. I just want to say your QT interval, that should be less than half an R to R interval to be normal. So the U wave, if it's present, it's typically small. This follows the T wave. It's thought to represent repolarization of the papillary muscles of the Purkinje fibers. If someone has a prominent U wave, that could mean the patient has hypokalemia, and of course you would want to ask the healthcare provider to get a BMP so you can look at that potassium. Moving on. So measuring time and amplitude. So with time, when you're looking at each little box, so that small little box, that represents 0.04 seconds. And of course, if you were in that big box, there's 1, 2, 3, 4, 5 small boxes. So when you're counting out, that would equal 0.20. So that's something that you need to keep in mind. Amplitude, we'll be discussing this later with EKG monitoring in another lecture. But with amplitude, just keep in mind a small box is 0.1, and then of course each large box would be 0.5. So, measuring the PR interval. And, you know, this is good to keep when you, I believe I uploaded for you, I think there's 14 rhythms. And so you're looking for, you know, first it discusses the P wave, the PR, the QRS complex, and so on. And then you have to give the interpretation. I would suggest that you go back to your PowerPoints when you're measuring so you can see where exactly you need to measure. So again, the PR interval is from, you measure the beginning of the P wave to where the Q wave takes off from the baseline. So if you're looking at the top photo, that is 1, 2, 3, about 4 small boxes. So that would be about 0.16. So if you take 0.04 and multiply that by 4. You get 0.16. Now the normal PR interval, yeah, you're going to have to memorize this. It's 0.12 to 0.20 seconds. And just keep in mind that it is seconds. I've given quiz questions before, and I had 0.12 to 0.20 seconds, and then I had 0.12 to 0.20 minutes, and people just kind of saw that one first and they jumped on the minutes, and of course, and it was incorrect. So with measuring the QRS complex, you measure from where the Q wave takes off from the baseline to the end of the S wave. Normal QRS complex is less than 0.12. So if you're looking at the bottom photo, the one on the right, if I were to measure that, so there's 1, 2, 3 small squares. So 0.04 times 3 equals 0.12. Now, the picture to the left, this QRS complex looks a little different. So this is how you would measure it if it's similar to that, and that's just 0.08. Calculating heart rate. There's several ways to calculate the heart rate. You can do in a 6-second strip, which is what we will be looking at, the R to R intervals in 6 seconds, and you multiply that by 10. If you have a 6-second strip that is irregular, this is the way I usually count, R to R intervals in 6 seconds. But if the rhythm is regular, you count the number of small squares between one R to R interval, and then you divide this number into 1500. That's how you get the most accurate rate. But like I said, you can use that if the rhythm is regular. So when you see this 6-second strip, obviously you're going to count the R to R's and multiply it by 10, and that looks like it's regular. So the rate would be 70 there. There's other ways that you can count heart rate. I suggest you not use this since these are new to you. And essentially it just gives like a little countdown that you see there. But again, I just don't like that. It's kind of more of an estimation. Patient preparation. So ECG leads consist of an electrode pad fixed with an electrical conductive gel. So obviously we have men that are very hairy. You can get some soap and water, shave those areas with a razor. Other things that you can do, if a patient has oily skin, they're diaphoretic, you can use an alcohol swab. You can also use what's known as skin prep. They often use that on the nose to get off the oily secretions before you put that sticker across the nose. Those are just some pointers. The next slide shows artifact. In artifact, so after you've gotten all 12 leads placed on the patient, in order to get a good picture, the patient has to remain still. And so, you know, if they're shivering, they're moving their arms, you're not going to get a good picture, and that's just artifact. Telemetry monitoring. Just a thing to make note, and I think we discussed this last semester. If you have a patient who is on telemetry, and let's just say their normal is sinus rhythm in the 80s, but the tech calls up and said maybe they had a burst of PACs. So anytime someone changes from the baseline, you automatically should be getting a blood pressure, a pulse. Is the patient symptomatic? Did they feel like their heart was skipping a beat? Are they having any type of chest pain? Are they diaphoretic? Do they feel like they're going to pass out? Those are questions you would want to ask, and make sure you always document that. So, to assessment of heart rhythm, one thing you need to do if the rhythm changes, you want to kind of determine what's the cause of this. So, for example, tachycardia. Maybe this could be the result of a fever, and it can cause a decrease in cardiac output as well as hypotension. Electrolyte disturbances, that can cause dysrhythmias, so maybe you need to get a BMP. So what is cardiac output, just to review? That is the volume of blood ejected from the ventricle in 1 minute. So assessment of heart rhythm. So when you have your 6-second EKG strip in front of you, you're going to see the P wave, and there should always be a P wave in front of each QRS complex. So the P wave should always be upright. If it's inverted or absent, then that's abnormal. Your atrial rate and rhythm. So that would be by counting the number of QRS complexes, multiplying by 10 if it's irregular. If it's irregular, excuse me, I think I said that backwards. If you have an irregular rhythm, you count the QRS complexes, multiply by 10. If it's regular rhythm, you count the number of small boxes between the R to R, and then you would divide by 1500. So the PR interval, you would look at that next. And again, the normal duration is 0.12 to 0.20. Ventricular rate and rhythm, again, we've discussed that. QRS complex, typically normal duration is 0.08 to 0.10. In other books, it may be 0.08 to 0.12. Next, you're going to look at the ST segment. It should always be flat. If it's elevated or depressed, that's abnormal. The QT interval, it can be normal or prolonged, typically 0.36 to 0.44. And so a prolongation of the QT interval can lead to other dangerous dysrhythmias, such as torsades de pointes. So next here we have our first rhythm. And again, if you recall, the SA node can fire anywhere between 60 and 100 beats per minute. So follows normal conduction pattern. So first thing you look at is the P wave. So and look at every single P wave in the 6-second strip. And looking at these, each P wave, it's upright, and there's always a P wave in front of the QRS. Next, you would measure your PR interval, and then look at the QRS complex. And so if I were to measure this one, it would probably be around 0.08. Next, you see a T wave that follows each QRS complex. And so when I was talking about whether it's a regular rhythm, one thing that you should do, always get yourself a Post-it note, okay? And in order to determine the rate, what you do is you put your Post-it note like this, and then what I do is make a little black mark on each one here. And so I'll take this and I will, actually, let me make this a little bit darker here so you can see. All right. So if it's regular, you go from R to R. And in order for this to be a regular rhythm, and you have to measure each one. So that's regular, and this is regular. So we can say this is a regular rhythm. So if it's a regular rhythm, you can, now I want you to do the heart rate. So if I'm doing the heart rate and I'm looking at the first R to R complex. So there are a total of, and you're going to count the number of small boxes. So I'm going to say there's 5, 10, 15, 20, 21. So we'll say about 21. And so next, if you get your calculator out, you take 1500 divided by 21. And so the rate of this would be, comes out to 71.4. So we'll just say heart rate of 71. And that's how you would configure the rate. Sinus Brady. So the SA node is firing at a rate at less than 60 beats per minute. So typically the rhythm is regular. So again, you're going to take your little post-it note here. And first thing, we'll look at the P wave. There's a P wave in front of each QRS complex. Next, you would measure the PR interval, measure the QRS complex, and there's a T wave followed by each one. So you're going to, put your little post-it note on the R to R, which is here. And then you're going to measure each one. And okay, so that is a regular rhythm. The next thing you would do is determine the rate. So again, if I had to determine the rate for small boxes, there's 5, 10, 15, 20, 25, 30, 35, 40. And I'm going to say 43. So I'm going to take 1500 divided by 43. That equals a heart rate of 34.8. So I'm just going to say 35 beats per minute. Now, an example, I eyeballed this. Now, if you look down, I used 40 here. So if you do 1500 divided by 40, it's 37.5 beats per minute. So sinus bradycardia, it's a normal rhythm in patients who are aerobically trained athletes. You can also have bradycardia during sleep. Athletes, they typically have a larger stroke volume. So they have a greater volume of oxygen that's delivered to the body per heart rate. It also can occur in response to the parasympathetic nervous system as well as drugs. So if someone, an elderly patient, is bearing down and having a bowel movement, they could vagal down, they could pass out. Other things that can cause sinus bradycardia, obviously medications, beta blockers, remember, end in OLOL, calcium channel blockers, and pine. Associated diseases, if you recall, we talked about hypothyroidism. That lowers the heart rate. I'm not going to read down through manifestations. Treatment, atropine is typically given. It increases the heart rate, improves conduction by blocking the parasympathetic nervous system. A pacemaker, this helps to stimulate the heart muscle to contract. Also stop the drugs that I mentioned, such as DIG, beta blockers, calcium channel blockers. So I'm going to stop this here and I'm going to make a second video.